So what I'm going to talk about today is digital disease detection. And what that is essentially the idea of doing epidemic surveillance using as many digital tools as we can. And I come from HealthMap, which is based in Children's Hospital Boston, but despite the title, we also care about adults and elderly people. So this is not just aimed at children. But what I'm going to talk about today is the HealthMap system. I'm going to talk about the digital disease detection that we do. I'm going to talk about how we do it, which is a little bit of an under-the-hood take of the behind-the-scenes back end. I'm going to talk about why we do it, and this gets a little bit into the international relations aspect and looking in at trends and how the reorganization of public health information flows, what that means for the larger picture beyond public health. Then I'm going to look at how we're trying to expand HealthMap data collection, so doing more epidemic surveillance more intensely as best we can, and then also talk about expanding the digital disease detection concepts beyond the simple kind of epidemic disease model that we've primarily built our brand on. So for those of you who aren't familiar with HealthMap, this is it. So if you go to healthmap.org, this is the website that you're going to see. And if you're not a public health professional, it might be a little bit confusing. But so I want to break it down a little bit just so you have some idea of what's going on. So what you see on the map are what we call alerts or events. Now these are public health events going on throughout the world that we have detected through one of our myriad sources that we pick up throughout the globe in multiple different languages. And if you're playing around with our system, what you'll see is you can roll over the individual pins and it'll tell you what disease you're looking at. And if you click on a pin, you can kind of get a more detailed view specific about that particular event and even go to the original source where we picked it up. So say it was a newspaper in Pakistan, we've got the direct link that takes you right there. We've got sections for comments. We've got ways that people can interact to give us more information and find out more information about specific events. So I'm going to talk a little bit more about this later, but just to give you a better idea of kind of some of the other stuff that we're doing, if you look at the tabs at the top, so we have a globally focused website, but we also have a locally focused website, which it's got a little bit cut off, but this is, I pulled this up while I was in Boston. And so this is a map of Boston with all of the events within a 50-mile radius of Boston. So if you sign in to healthmap.org and you go to your local site, you'll be able to get all of the epidemics that are happening in your area classified by different types of diseases. And we also have a section called News. This is about 6 months old. This is what we call our Disease Daily, and this is we have information on diseases that are currently going on. We actually are sometimes the first to break the news in English. There's a number of stories that we pick up in other languages that haven't necessarily made it into the English language press, and so we put those on our website here in original content. And we also occasionally have commentary and sort of a monthly series. We're talking about disease eradication pretty soon. We've also had series on mass gatherings because that's a point where there might be a lot of epidemic transmission. That is that's the very broad overview of what we do. Now the question is, how do we do it? So this is when we start to get into a little bit of the technical aspects of HealthMap. So what you'll see in the upper left is we've got newspapers, RSS feeds, and that little person is people like you. We've got people all over who are contributing information. We take all of this information and we have 93 different feeds is what we call them. And we have 93 different feeds that look through, this number's outdated, somewhere around 80,000 different websites that go through them in 9 languages every hour, on the hour, 24 hours a day, 7 days a week. So this is an automated system that we have pulling in all of this data to create the map that you've already seen. So this results in about 2,000 alerts per day on average that end up going on our map in about 10,000 plus precisely placed locations. So how do we do this? So all of the articles that we're pulling in from all these different feeds, what we do is we use natural language processing to pick out the disease, the location, case-related information, and any other associated information such as additional locations, or if it happened at a school or a correctional facility, things that tell us a lot about what kind of risk factors might be associated with the epidemic. So then we start classifying, and we can classify these. We can classify these according to locations, species, disease patterns, and case and death counts. We have over 240 diseases in our database, so it's pretty hard to stump us. It does happen occasionally, but we start the classification process here, and we continue with the Bayesian filtering process. Bayesian filtering is essentially a spam filter. It's the same technique that your spam filter uses for your email, and we use that to classify our HealthMap alerts. And we can do this with over 19 million phrases in an automated fashion with 91% accuracy in English. We classify them into 5 different categories. Breaking news, and these are the breaking news and warnings are what appears on the map. And breaking news is essentially any new outbreak or new information about an old outbreak. And that includes information about new cases or new locations. Warnings are things, for example, if there's mosquitoes in Denver that are found with West Nile virus, that's something that'll go on our website. And it's a warning because no one's actually been infected yet, but people should watch out. Old news is things like, plague in the 14th century. Context is there's lots of important disease-related things that are discussed in the news, such as research on influenza or outbreaks of diabetes. But these, because they're not emerging epidemic events, aren't necessarily going to go on our map. And then not disease-related, you'd be surprised to find out how many outbreaks of tornadoes and outbreaks of corruption that we find in our sources. So once we've categorized them all, we take the ones that are going to go on the map, and we classify them based on a machine learning program that we've used to decide essentially the risk that each event might pose and its significance. And we classify the yellow as the least kind of risky and the red as the most risky. And don't forget, it's a relative scale, so yellow is still risky. But red is probably something like polio, something that would definitely kind of rally the troops. So once we've gathered all that information and classified and categorized, then it goes on the map. And this is something that happens every hour on the hour in English, French, Spanish, and a couple of other languages in an automated fashion. And what we do is we have that go automatedly, and then only after it's on the map, we have a curator, someone with public health experience, go through and look to make sure that the disease is correct and that the location is correct. And occasionally, certain things happen, like there was Ebola that was placed in Massachusetts, and that's something that we correct within 24 hours, because that did not actually happen. And once we have all of that information, then we gather the picture that you've seen here. And one of the things, you might be sitting here and be like, all right, what do I care about epidemic diseases? I'm not, I like health, but really, like that much? But I just want to stress that this is something that not just public health practitioners use. It's used by clinicians. It's also used by people like you, because how many of you're at a School of International Relations? How many of you are planning on taking an international trip in the next year? Right, so almost everybody. Right, so you're probably, I would recommend, go to a travel clinic and seeing a clinician to discuss travel-related things that you have to worry about. But I would also recommend coming to HealthMap. And when you do, I would click on the advanced search, which is right next to the search bar, and I would look specifically at the, you can look at particular diseases. Do I have to worry about, African horse sickness where you're going to go? Probably not. Do you have to worry about specific locations? Are you going to multiple countries? You can choose. The feeds, these are the feeds that I discussed. We've got 93 of them. They're everything from as official as you get, the World Health Organization, to about as unofficial as you get, which is the person sitting next to you, right? So we've got a continuum of official sources and unofficial sources that you can choose how valid you want your information, and you can choose a time period. So what I'm actually going to Morocco in about a month. So what I would do is I would pick the time period as the past year, see what's going on in Morocco. And Morocco, like a lot of Arab countries, it turns out, has a lot of foodborne illness. So I'm going to be very careful about the food that I eat. And I'm also probably going to bring some Cipro. So when you go to that travel clinic, you can go armed with a little bit of knowledge, being like, I know I'm probably going to get X, Y, or Z. How much do I need to worry about that? So I would recommend this even for you and your friends, any places that you're going. But keep in mind, don't forget, a lot of our information is coming from news sources. So if you're going to a place like China that controls the media, then the only thing that you're going to see on our map is what the Chinese government wants you to see on our map. So So that's something to keep in mind. So who uses HealthMap besides you? HealthMap is used by Centers for Disease Control, the World Health Organization, state and local public health departments, NGOs. We even had an exhibit at Liberty Science Museum in New York, clinicians like the doctors you might go to, travelers like you guys. But one of the things I wanted to focus on here, and this is kind of the international relations-y part of my talk, is the World Health Organization. It kind of seems really obvious that we have a HealthMap website on emerging infectious diseases, and the World Health Organization uses our website on a daily basis. The funny thing about that is 20 years ago, this was not allowed. So to go off on a tiny bit of a tangent, I just want to say a couple things. And by the way, you can tell the slides that our graphic designer did and the ones that I did. So this was one, if you can't tell, this is one that I did. But just a little bit of a history about the last smallpox epidemic that occurred in Europe in 1972. I don't know if any of you have heard about this, but it was a very large epidemic. Europeans were very worried about it. 175 cases. Tito, the dictator at the time, put a huge clamp down on the entire country, closed off all the borders, forcibly vaccinated somewhere around 2 million people in a matter of weeks. So I mean, a huge rapid response to a smallpox outbreak. How did it happen? This is where we start to get into some issues of international relations. So it started because there was a family in Afghanistan that trekked over land to the city of Mashhad in Iran. This was a Shiite Muslim family, and they were going to this pilgrimage site there. On the way, they happened to pick up smallpox. So while they were there, they spread it to a lot of other Shia Muslims who then contracted the disease, and there was a burgeoning epidemic of smallpox in Iran. So this is 1970. 1971, unfortunately, happened to be the 2,500th anniversary of the Persian Empire. The Shah had this huge celebration plan where leaders from all over the world were going to be coming in, celebrating this. It was going to be his big, big moment. He was not going to let an epidemic get in the way of this. So the problem with this was, here's an epidemic, it's raging, and the Shah is not reporting to the WHO because he wants to make sure that everyone still comes to his party when he has that anniversary. So the problem with that is, you can't really go to the WHO and say, hey, we need some help, like, can you give us some of your vaccine? We've got an epidemic, when you're not claiming that we don't really have an epidemic. So unfortunately, the Iranians had to use the vaccine that they had developed in Iran, which was only 65% effective. So despite mass vaccination campaigns, you still had a lot of smallpox that was continued to grow. And it continued to spread throughout the region, spread to other, particularly Shia Muslim pilgrimage sites in Syria, in Damascus, and in Iraq, such as Baghdad and Mosul. So then, okay, so this is 1971. We get to the Hajj in 1972. What happens? So we have small epidemics in these Shia pilgrimage sites, and then we have a pilgrim from Yugoslavia, particularly Kosovo, who's on his way back from Mecca, takes a bus through all of these Shia pilgrimage sites, and then goes to Yugoslavia. And that's when you have the last European outbreak of smallpox. So on all of this, if you notice, I barely mentioned the WHO. Because what was the WHO doing? It was sitting there with its hands tied while the Shah sat on the information that he had about smallpox. In Iraq and Syria, it was a pretty similar situation. Information flows were not going very well. So this is a problem. And this is a problem that some of you guys probably also face with not just infectious diseases, but when you talk about any sort of problem when you're dealing with, sorry, kind of advanced a bit quickly here, with any sort of collective action problem at the level of states. So states have realized that international diseases represent a collective action problem. You've got to collaborate, otherwise diseases are going to spread. You know, there's the famous quote that diseases respect no borders or boundaries. So what can you do about this? So in the early 1800s, there were a lot of cholera outbreaks based on international travel that France and a number of countries got together and started to say, okay, we need to have some sort of thing that brings us together that helps prevent the spread of these diseases. And that was the International Sanitary Conference in 1851. It sort of regulated, when quarantines were allowed, how long a quarantine would be. It would be for 40 days, because it comes from the French word for quarantaine, which means, around 40. So, and then these rules just kind of get passed down until the International Health Regulations were signed in 1951. And they were revised in 1969. What did they do? So they basically said WHO needs to find out information. States must report information about cholera, plague, yellow fever, and smallpox. And the WHO is only allowed to act on official information. Remember smallpox, Iran? Was there any official information coming out of Iran? No. So what could the WHO do? Nothing. So what did the WHO do? They got very good at sending sternly worded letters. So if you go to the WHO archives, you're going to see a lot of sternly worded letters that say, like, country A is really annoyed at country B because they're doing something. So they send a letter to the WHO saying, stop country B from doing this. WHO sends a sternly worded letter saying, country B, stop doing this, or we're going to have to send another sternly worded letter. And they might do that. And unfortunately, so what kind of incentive does this do for anybody? Nobody did anything. It led to frequent repeated violations, as in the case of Iran. You'll be able to report that disease a little bit later. So what does this mean? So this is, we're thinking all the way back to Iran, 1971. Let's think about SARS. Everybody here, we were all alive for SARS. Everyone kind of remembers this. It was a big deal, right? So what happened in SARS? What's so important? So just a brief recap of SARS. SARS was an airborne virus that was spread primarily in China, Asia, and made it to Toronto. It was spread a lot through air travel, and it was kind of the WHO's shining moment. Like if you talk, I'm not joking, it sounds funny, but actually it was, in the sense that a lot of people said, the WHO's, it can't do anything, and they've pulled out examples like Iran, and there's a number of examples where the WHO basically plays second fiddle to whatever the big kind of, bully on the block wants to do. That bully is often China. Sometimes it's the United States. But this was the first time that seemed to change. So what happened? So right around SARS, a couple things kind of crystallized. So the WHO was unofficially using unofficial sources since 1998. So remember, international health regulations, they weren't allowed to use these sources, but they were. China and Ontario were not releasing case data. WHO knew there was an epidemic of SARS going on in these areas, but they didn't know what was going on through the official information. They found out through informal sources what was going on, and based on that information, released travel advisories for Hong Kong, Toronto, and some other areas of China later on. This had a huge impact. This had a huge impact because the economic impact of this was huge. Airline vacancy rates went down to about 50% of capacity. Hotel rates in Hong Kong went down to about 30% capacity. The economic impact of the WHO's travel advisories were gigantic and almost seemed punitive. So, if the WHO slaps a travel advisory on you, that has a huge impact on your economy. Guess what happened right after that? Everyone started working really hard to report things about SARS and doing a lot more epidemic reporting because they were really afraid that something was going to happen. China and Ontario really got their butts in gear, and and this is where people say it was a huge success. We don't have SARS anywhere right now. But a couple of people kind of took this new trend to extremes. Some people said that this was a new public health world order. This was a prominent medical journal. There was a guy who wrote a book that called SARS the first post-Westphalian pathogen. I'm not joking. That's the name of the book. And David Heyman, I'll read this quote in just a second, but David Heyman, he was the director of communicable diseases at the World Health Organization at the time of SARS. So it's really important when he says that the detection of an international response to the SARS outbreak clearly demonstrated that countries are willing to forego the exclusive privilege of reporting and responding to infectious diseases occurring in their own territories in a matter over which they have supreme control. He's basically saying territorial sovereignty doesn't matter anymore. So, that's, at an international relations school, we could probably laugh about that. But there were some things that this did have a practical impact on. One of them is that the WHO, I should step back a little bit. So, 1996, the WHO said, let's revise the international health regulations. 2005, they finally did. One of the things that really said, we've been in this process 8 years, SARS happens, all of a sudden everything congeals in about 2 years. Kind of tells you what SARS might have done. So one of the things that it did is, in the international health regulations 2005, the WHO is now allowed to use informal sources, but it's still reliant on soft power. There's still no enforcement mechanism. A lot of sternly worded letters are still going out. it says primarily that public health capacity needs to be strengthened, which is very true. And it, instead of focusing on disease lists, which SARS was on nobody's list, it focuses on a flowchart. Now, this next slide is a little bit difficult to see, but all that you need to see is the fact that it's a flowchart. What it does is every country has a person that is designated that whenever there's an event in their country, they're supposed to go through this flowchart and decide whether or not they should report it to the WHO. It has things like, is there a chance for international spread? Yes, no. Is this a dangerous disease? Yes, no. And if you get to the end and it says report to the WHO, you're supposed to do that within 24 hours. So this had a dramatic impact on how epidemic diseases are thought about. And this, don't just take my word for it. This is something we actually studied. So between 1996 and 2010, there were a number of emerging and re-emerging epidemic diseases that swept over the world in different ways. So one of the things that we did is we took the WHO's data on these diseases, and we looked at the amount of time it took from when the outbreak started to when the outbreak was actually formally discovered. And we examined the change in that time, the delta T right there, from 1996 to 2008. So in 1996, what you're looking at is it took an average of 167 days to go from outbreak start to official detection. You can imagine the number of people that started to get sick and the potential fatalities and morbidity that can come when it takes basically almost a half a year for an epidemic to be detected. Well, and then it shrinks, and we're looking at, by 2010, somewhere around 20 days. It's still about 3 weeks. We can do better, but still it's a lot better than the 167 days previously. And, and there's definitely not enough data there, but you can probably say that things got a lot better post-SARS in 2004. So this is something that we think, this has had a dramatic impact. Where's this dramatic impact come from? It's come from a lot of things, the international health regulations being one of them. But we like to think that it's come from changes in the way that epidemic diseases are being reported. So here's the old way that it was done. Now, keep in the back of your mind, Iran, smallpox, okay? So back in the day, an Afghan family had a disease, and they might have gone to a doctor, might not have. The doctors, once they found out about it, they might have reported to some local public health practitioners who might have gone to local officials, sought some laboratory confirmation, and then it might have gone to the Ministry of Health who hemmed and hawed over it before they got the kibosh from the Shah. So then after that, only then does it reach the WHO. So you're looking at this very hierarchical process. So one of the things that we think is happening in this kind of decline in the amount of time it takes from outbreak start to outbreak detection is that digital disease detection has enabled a flattening of this hierarchy. So what you're looking at now is spokes on a wheel. The idea that using digital disease detection, you can have all of these parties communicating not in hierarchical ways, but a certain amount of free flow of information that allows these people at the smallest local level to get information about outbreaks going on anywhere without having to go through all the official channels. So we think this model has been working well, and this model has been working well since ProMed, and it's hard to see, but this is the Global Public Health Intelligence Network. It's a Canadian group that was essentially the first group that did web crawling, kind of like what we do at HealthMap. They started in 1998. ProMed started in 1994. ProMed's the first infectious disease social network. It's essentially a listserv of infectious disease physicians all over the world that share information about disease outbreaks. They were actually the first group to report anything related to SARS in 2003. But since then...
Just a quick, is there information available, like archived in data sets that you can access?
ProMed has a ton. GFIN, you have to register, and if you're at an academic institution, you can register. I don't know if they'll give you their data. It's a good question. I've never asked for it. But ProMed, all the data is available online. I mean, it would take a fair amount of cleaning, but it's there. It's all public. And you can join ProMed if you want a lot of messages in your email inbox about blue tongue and like other cattle diseases. Like you can get that, but. If you're interested. But so these guys were the forerunners, and since then, there's been a lot of other people, including us, that have come into this and are working on different aspects of digital disease detection and doing it in different ways. So we think there's a lot of ways to get better at this as well, and a lot of people are working on this. And the reason we think this is because when you think about it, if you're looking at an epidemic curve, where do you think like newspaper articles and some of the things that we're detecting in HealthMap come? They probably come a little bit towards the end. It's got to get big enough for a reporter to care about it and an editor to care enough about it to put a reporter on it for it to get reported on. But there's a lot of chatter going on before that. There's probably things like Facebook and text messaging and Google searches, things like that that are all happening before you finally get to things being talked about at the infectious disease physician level or blogging or anything like that. So what we'd like to do is we're aiming a little bit more at the start of the epidemic curve as a way to try to get a little bit of a jump on some of this digital disease detection. So to do that, one of the things that we've been doing is we've been working with ProMed, and you can see a little bit of a mini health map here, and you can see some of their data, the most recent data right here. So this is ProMed, and you can go to their website. We've been working with them with the idea that leveraging some of these infectious disease social networks is going to be really useful because, I mean, obviously it was useful for SARS. It's going to be useful for other epidemics in the future. And the way we work with them is we do a lot of the data collection because we can augment their systems of infectious disease physicians all over the world, and we can augment that with our data. So we could give them a lot of our data. They look at it, and they've got a lot of infectious disease physicians all over the world that get to say, hey, this is something we probably have to worry about, or this is probably something that we don't have to worry about, because especially in some, in Arabic, the word for smallpox and chickenpox, not surprisingly, it's kind of similar in English, is very similar. And so there's lots of reports of basically smallpox that turn out not to be smallpox. So we send them that information, and they're able to say, actually, no, this wasn't really smallpox. The symptoms don't match with smallpox. And then they send it back to us, and we put it on the map. So this is, so we can add a lot of value to what different groups are doing. And we've got this kind of collaboration with ProMed and with GeoSentinel. GeoSentinel is, if you guys do go to a travel clinic, it's a group of travel physicians that once you come back from abroad, if unfortunately you happen to be sick, your travel physician has the option, if they would like, to anonymously report any de-identified information about your illness in terms of where you were, what you were doing, and what you got. And that's information that we also put on our map. And so leveraging these kinds of information sources is a really useful way to get a sense of what's going on internationally throughout the globe. And it adds more information in a little bit more of a validated way. You're looking at public health professionals, clinicians, that are really a lot more solid about what they're saying than what a reporter might be saying about a disease they know nothing about. So one of the things we're looking at doing next is expanding this beyond just the public health professional and expanding it to people like you. And so it's something that we call participatory epidemiology. And the idea behind it is very much, it's basically crowdsourcing epidemic diseases. It's the idea that, people in the community like you would report things that are going on, like I'm sick, my brother's sick, seems like he has flu or is diagnosed with strep. And that information can go into our database, and it can be reviewed. And once it's been reviewed, put onto a map, and then in the aggregate, this information can actually be quite useful. So we started doing this with an application that we have for the iPhone called Outbreaks Near Me that we released in the middle of the swine flu epidemic in 2009. And this has actually been quite a popular application. We got over 100,000 downloads, and we've just recently released a new version. What it does is it's basically a miniature version of what I showed you on the local page on the HealthMap website, which is it's got a map that gives you your local area and all of the epidemics within the local area. It gives you a list of those epidemics. It allows you to submit a human or an animal report if you've found anything. And those reports do get curated. We occasionally get some strange ones, like we've gotten reports of roadkill, and those don't make it on our map. But a lot of things do. We actually have a very low threshold, and we also have news, which is essentially a feed of the disease daily, and you can get information about HealthMap and what we do and things like that. So I would encourage you to download this, and if you don't have an iPhone, we're just about to release the Droid version. So you'll be able to get it hopefully any way that you can. The big question is signal to noise, because you can imagine one individual report might not necessarily be accurate. But the thing that we found out during H1N1 is that in the aggregate, these reports seem to be pretty accurate. Now what this graph is this is a graph of CDC's ILI, which is influenza-like illness, which is it's a surveillance system of emergency rooms where people come in and have diseases that look like influenza. So they've got this. It's released about 3 weeks after the fact, so it's kind of late. And we compared that to the number of submissions that we got from outbreaks near me that related to H1N1, normalized by the number of downloads. And what we saw is that for certain periods in the epidemic, we actually had a pretty close correlation between CDC's influenza-like illness and our reported events through outbreaks near me. So we'd like to take this further. And the goal is to try to engage users through some geospatial recognition. For users that opt into this, what it would do is we'd be able to, if you provide us with your location, we'd be able to provide you public health messaging tailored to your specific location, and we'd, in return, occasionally ask you for some help in figuring out what's going on with some of the undiagnosed events in HealthMap. Now, these happen all over the world of there's an outbreak of something, but we don't know what it is. And the difficulty is getting more information about this. And so what we imagine is finding events that might be undiagnosed and finding people that are within the geographic area surrounding it and sending them push messages that say, hey, do you know anything about this? And this is something we're starting to work on to see if we can kind of incorporate this and do this in ways that respect people's privacy enough, but also kind of give useful information. But this isn't the only way to submit. If you want, you can give us a call at 919-MAP1BUG and leave us a message. You can also, we have a Facebook application called Outbreaks Near Me with some cute little microbes. We're also on Twitter, so at HealthMap, let us know if anything's going on. And of course, you can report via the website. So we've actually gotten quite a number of user submissions, and we generally like to encourage these. So over quite a large amount of time, we've gotten over 1,000 alerts, and some of them, obviously, some are more useful than others. Roadkill, less useful, but this particular event turned out to be extremely useful. So there was a London-based doctor who used Outbreaks Near Me to report that his family in India had chikungunya. Chikungunya is a mosquito-borne virus that causes a pretty painful disease. Chikungunya, I forget exactly what it means, but it has something to do with the symptoms in a language spoken in northern Malawi, I think. But needless to say, it's not a great disease to get. Its symptoms are similar to dengue: high fevers and a lot of malaise and stomach pains. What they did is we had some information that there was an outbreak of something going on there because the hospitals were full. But the Ministry of Health wasn't releasing any information. So this doctor's report, he was telling us that his family was sick, that everything was full, Ministry of Health wasn't reporting, and that the disease was chikungunya, came out days before anyone else released that the disease going on in this part of India was actually chikungunya. So we're trying to reach out to people in multiple ways, including through, I don't know if anyone happened to see the movie Contagion, but they had a kind of a public awareness campaign surrounding Contagion's release, and so we worked with them and we developed a HealthMap skin that went on the Contagion website called Pandemic Pulse. And so these are all things that we've been trying to do to try to get people to crowdsource epidemic surveillance. But we've also been turning to trying to figure out some way to incentivize this. So you can imagine with incentives, we would hope to increase the number of people that are providing this information. It turns out this does work pretty well. We've got an application called Flu Near You, which you can go to flunearyou.org. And if you went there, you would be asked to sign up for Flu Near You. And once you signed up, this is what you'd see. You'd see a map, and this is obviously, I'm from Massachusetts, but so you'd see Massachusetts and you'd see all of the essentially reports, all of the surveys precisely placed to the zip code of where people have been reporting. And all the green dots are places where people are not sick. All the yellow dots are where people have some symptoms, and the red dots are where people have symptoms that look a lot like flu. And you can compare this to the the CDC's influenza-like illness level down at the bottom. You can also get information down in the lower right about locations of vaccination centers near you, and information in the aggregate on the number of reports in Massachusetts. And what this has is these are weekly surveys that go out. Once you sign up, you'd get a weekly survey that asks you what symptoms you might be having, when did you have them, have you ever gotten the flu vaccine in the past year, things like that. And the point of this is not just to have individual people report, but the point is also to make it viral as much as we can. Because you can, once you sign up, you can invite friends to this, and they can invite friends that are also linked to your account. And the important thing is, for every survey that is submitted week by week by week, that gets tallied. And the tallies can have a pretty big impact. So the goal of this challenge is to hopefully get people excited enough where an individual could win $25,000 if they're able to get enough people to report. And so $25,000, $15,000, and $10,000 for third place isn't bad. The difficulty is, read the fine print. So 10,000 person forms minimum. So when you do the math, if you have 100 friends that submit every week, they would need to do it for 100 weeks. This contest is going on for a year. So it needs to be a little bit more than 100 people trying to make this as viral as you can, and the more information you get, the greater your chances of winning $25,000. And there's also group awards, such as at Corbell School, for example. If there were a lot of people at the Corbell School that were able to get involved in this and were able to meet the threshold, the school itself could win $50,000. I think that'd be a pretty sweet party. Yeah, so I grabbed a screenshot of kind of this is what's going on in Denver. So right now there's not too much. So there's you guys got your work cut out for you. And this is what's going on. It's in association with the American Public Health Association. So there's basically any center where there's a lot of people affiliated with APHA, there's going to be a lot more reports. Yeah.
Why is like West Virginia and stuff blue when they're at Pennsylvania?
So good question. So it's coming from the CDC's influenza-like illness. So the background colors are related to how much the influenza activity the CDC is picking up in that area. Good question though. Yeah. So I mean, any questions so far? Right. So the next thing that we're trying to do is we're trying to take digital disease detection beyond simply detecting epidemic diseases. So some of the things that we're trying to do is do a little bit more surveillance in different ways. We're doing some tropical disease surveillance of endemic diseases, so not the epidemic diseases, but endemic diseases that are there constantly. Disaster surveillance, mass gathering surveillance for things like the Super Bowl or the Hajj, or we've done it for the Olympics, and we've done it for the World Cup. Vaccine confidence surveillance, which is something that I'm very interested in. Trade in illegal wildlife. This is something you can also track using digital disease detection technology, and doing some human rights abuse tracking, which I'll go over. So have any of you heard of something called Google Flu Trends? This is something that made a lot of news, yeah, so it's not that uncommon. A lot of people have heard of it. Essentially what it is Google figured out that you can actually get a sense of when flu is happening in certain geographic areas by what people search for in Google. So if they search for things related to flu, like fever, sniffles, cough, things like that, places where those search queries are increased are places where there's actually a lot more flu going on. So, it's a logical concept, and it's something that we were able to work with them to expand beyond influenza to dengue. And dengue, I don't know if, imagine you guys might not know much about dengue. It's very common in Latin America, it's common in parts of Asia. It's a difficult disease because there's 4 different types, and if you get type 1, then you're immune to type 1, which is great. The problem is, if you get type 1 and then you get another type of dengue, there's actually an increased chance that you could have a more severe infection. So dengue, the more different types of infections you get, the more you actually have a chance of getting some really bad complications. So it's an important thing to know kind of what kind of dengue activity is going on in your areas. So we worked with Google and we got data from Bolivia, Brazil, India, Indonesia, and Singapore, and correlated that with search queries in all of those countries, and figured out that, not shocking, when people are searching for things like mosquito control, or mosquitoes, or bug repellent, or dengue, or fever, things related to dengue type of symptoms, that correlates very well with the amount of dengue that's going on in any specific area at any given time. So if you go to google.com/dengue trends, you'll be able to see some of these interactive maps for these different countries. And we were able to get a nice paper out of it that if anyone who's about as nerdy as I am can go read. So we've also been turning the digital disease technology towards surveillance in disasters. So HealthMap in 2010, about October 20th, we were one of the first groups to pick up that a watery diarrheal illness was being transmitted in Haiti. And very soon after that, the epidemic exploded. But we started right when we got this information, we started talking to our collaborators at Crisis Mappers and Humanity Road. And within 72 hours, we were able to put up a site where we were able to take information from people who were working on the ground in some of these humanitarian agencies, who were able to provide information using Twitter, using SMS, and sending it to a clearinghouse that we were able to scrape automatically 24 hours a day, 7 days a week, that put information on the map. And it's in a crisis situation, the information that's coming out, you have to, of course, be aware that it could change at any minute. And so this was constantly being updated and with information not just on number of cases, but on places to get safe water, places where there were refugee communities, things like that were useful for people on the ground. So this kind of event surveillance is something that is very easily adaptable to the HealthMap platform. And it's something that we were very excited to be able to do with these collaborators. And it's the kind of thing that did not take much time to set up and can very, very easily be adapted to multiple different types of crises. But Twitter wasn't only helpful for kind of what we were doing for people on the ground doing aid work in Haiti. It was also helpful because a large number of people tweeted about the Haiti epidemic. And we thought, hey, would it be possible to look at the volume of Twitter postings, looking at the volume of tweets, and what does that have any association between the number of cases that we might be seeing in Haiti itself? So we looked into that, and it turns out, this is a bit of a complicated graph, so I'll unpack it for you, but basically anywhere you see blue, the blue lines represent the number of hospitalizations, the number of hospitalized cases of cholera. The red represents HealthMap alerts, and the green represents volume of tweets. And so HealthMap alerts and volume of tweets actually pretty closely associates with the actual cases. The beauty of this is the Haitian Ministry of Health takes them about 3 to 4 weeks to get you those case numbers. Twitter and HealthMap will work a lot faster. So we've also been trying to expand this in different ways. So one of the difficult things about HealthMap is you look at the map and you're like, wow, there's so many alerts. What do I have to care about? And unless you have some public health knowledge, it's really difficult to get a sense. So we've been trying to work with different partners to contextualize some of these alerts. So we've been working with biodiaspora to understand how global migration patterns might affect the international spread of infectious diseases. So biodiaspora, they have information from the International Air Transport Authority, which is really tough to get. Turns out it's about $150,000 to $200,000 just to get this data. But once you have it, you're able to look at travel patterns all over the world. And so they're able to build graphs like this, which this is airport traffic in Jeddah. So this is the number of passengers that are passing through the Jeddah airport between 2000 and 2010. And every little spike you see, that's Hajj. And every little bump that you're seeing summer tourism festivals, and you're seeing Ramadan. So one of the interesting things about this is our collaborators at Biodiaspora like to liken this to an EKG. Now, I know I'm not speaking to a clinical audience, but an EKG is essentially an electrical tracing of your heart. You can look at your EKG, and it can tell you if you've got a problem going on in your heart, and it can also give you an idea of what kind of problem you have. So it's really interesting when you look at graphs like this for places like New York, Vancouver, and you see really, really vast disturbances around 2001, not surprisingly. So using this kind of information, you can probably predict, if there's going to be disease transmission in Jeddah or through Jeddah, when is it going to happen? Probably around Hajj. So this is something that we've been working with them to build maps based on looking at where are pilgrims going to be coming from and going to Hajj, and looking really closely at those countries to figure out what diseases might be transmitted between these locations with Jeddah as a hub. So we've done this for the Winter Olympics in Vancouver, where we were one of the first people to show that there was a travel association between measles in Australia and measles in Vancouver. And we also did it for the World Cup in 2010, where there was another measles outbreak between South Africa and Argentina. So this is the kind of thing that we call this anticipatory epidemiology, because you can kind of see the writing on the wall. And so if you put all your ducks in a row and you get a sense of what might be coming, then that hopefully can give public health officials a little bit of lead time and advance warning to get a sense of how they might be able to handle some of these outbreaks. So on that note, we've been trying to take that a step further with a project that we've been working on, again with Biodiaspora and the CDC, in something we call Biomosaic, which is trying to, once again, contextualize those HealthMap alerts. And we're trying to contextualize it on 3 different axes: on demography, migration, and health. And you might wonder why foreign-born is at the center of this. Foreign-born is really interesting. So a lot of you might have experience working in NGOs, and you'll understand this, but the main reason why foreign-born is there is because that's what the funder wants. So the funder is the Division of Global Migration and Quarantine, and they're very interested in foreign-born populations that are living in the United States. So we are very interested in foreign-born populations living in the United States. And what's interesting about foreign-born populations is foreign-born populations, when they first arrive in the United States, not surprisingly, have rates of infectious diseases, particularly tuberculosis and hepatitis, that are very similar to the rates of those diseases in the countries they came from. Not shocking. What's interesting is over time, those rates decline. And for things like tuberculosis, it's interesting because they actually never do reach kind of the native-born American citizen level. So they always remain a little bit high, which is one of the reasons why DGMQ is interested in this. But the flip side of the infectious disease is chronic diseases. So it turns out foreign-born people, relative to Americans, have lower rates of chronic disease. That the longer they live in the United States, the more lifestyle changes happen, the more obesity, cardiovascular disease, and diabetes come, and those rates of chronic diseases go up. So there's an interesting risk profile here. So if you're interested in foreign-born groups, you're interested in studying them from multiple different categories along the demography, migration, and health axes. So what we're trying to do is we're trying to build an application that has all of this data loaded pre-crisis. Anything demographically that might give some idea of vulnerability, like socioeconomic status, acculturation, education, linguistic ability, linguistic isolation. On the migration side, we've got border crossings, air transport, secondary migration, because there's a lot of refugees that arrive in the United States that then migrate a second time to places where there's larger communities of that particular population. And on the HealthMap side, on the health side, we have HealthMap alerts, and we have other endemic disease data and tuberculosis data. And the idea is, if you have all of this in a platform, then you'd be able to, when there's a crisis, just add a little bit of data specific to that crisis, and then you've got a fantastic application for doing some risk analysis work. And I just want to say, like, if you come from anyone else comes from a background in environmental sciences or geology, you're going to kind of laugh at us, because some of what we've been doing here in terms of the maps that we've been making that look at vulnerability based on like education or income, and that we've been putting into our application and combining with some of this other contextualized information, it's one of those things where in public health, this is literally the cutting edge. If you come from environmental sciences, you've been doing this for 10 years. So it's always one of those things that it's almost embarrassing when we go to, it's great when we go to public health conferences because we get a lot of oohs and ahs, but when we go to conferences about mapping, people are like scratching their head. They're like, really? But you got to start with baby steps somewhere, so even in the public health community. So if you guys do have a mapping background, if you need jobs, start knocking on health doors, because this stuff is just starting to really kind of grab hold in the public health community. And so just another screenshot of some of the other data that we have in terms of foreign-born populations and hospital locations. In addition to this, we have another project that we've been working on with the people at the I believe it's the World Wildlife Federation. Sorry, not 100% sure of that. I'm blanking on who exactly we're collaborating with. But what you see here is this picture was taken in Thailand in an animal market. And you're seeing, it's kind of a little bit hard to see, but if you stare at it for a little bit, you can see some monkeys that are packed into the same cage as a bunch of turtles. So what you're seeing here is looking at the human-animal interface is really important, because SARS actually started because it was a coronavirus that was originally in civet populations that somehow jumped species into humans. So we've thought, hey, if you can start tracking some of these wildlife, one, it's good because you're tracking wildlife, and two, because you might actually be able to track infectious diseases with it too. So, the good thing about it is you can use some of this informal surveillance because you're not going to pick up this information in any other way. It's such a clandestine industry that how can you get this information? Nobody advertises like, hey, you want a tortoise? That just doesn't happen. There's a large number of species and are captured and poached, and they're used for multiple different purposes. So so the market for this is actually a lot more diverse than you might think. It's also really going unnoticed and unmonitored, particularly in countries that lack capacity to do surveillance on these kinds of things. And there's also, as I mentioned with SARS, there's often a direct linkage between zoonotic diseases and human-to-animal interfaces. For those of you, if you did see Contagion, I'm not going to spoil it for you, but this kind of idea is very important in that. So if you go to healthmap.org/wildlife-trade, this is the map that you could see. You'll see less alerts. We always kind of try to bring in more alerts so that you can see what's going on. But so these are the kinds of things that we're picking up. It's actually very interesting. In India, we've picked up a lot of things. And what's the most interesting thing about it is we've picked up almost all of the events. If you put a map of the rail infrastructure of India overlapping all of these alerts, it almost perfectly coincides. And we think it's because, for some odd reason, the illegal traffickers seem to be doing a lot of this on rail, and that's where they get picked up by the police. So I don't know, we still have a lot more work to do on that, but it's kind of an interesting finding. So this is just a word cloud, looking at kind of all of the alerts that we have, what are we picking up? So there's not illegal trades in rhinoceroses, there's illegal trade in their horns. And elephants, not being illegally traded, but their tusks are. A pangolin, I didn't know this, but it turns out that is, I believe it's either an anteater or an aardvark. I get my A's confused. But it's often used as game meat in China and in certain parts of Africa. I didn't know that before this project. But you can see kind of the different kind of distributions that we're picking up here. So next, we've also been looking a little bit at vaccine confidence. Now this is important. I don't, unless you're in the health field, I don't know how common these things are for people, but who remembers 2003 where there was a big polio outbreak in Nigeria? Does anyone? Yes. So just a bit of background on this. So northern Nigeria is primarily Muslim, while southern Nigeria is described as multiple other different languages, multiple other different religions, including Christian. So there's a little bit of a not just an ethnic and linguistic and religious and cultural divide. There's a lot of things going on there, but there's also a little bit of a divide in terms of vaccinations as well. So there was a vaccination push in Nigeria in 2003 that was boycotted, and it was boycotted because there were rumors going around that the vaccine could either cause sterility in women, or the vaccine could cause HIV. And this was unfortunate, obviously. It was spread like wildfire and caused a vast boycott that led ultimately to 10 months of no vaccination in one of the last regions in the world that had endemic poliovirus. Now, what did this mean? This meant that the number of polio cases in northern Nigeria dramatically increased, and unfortunately, that meant that it also spread throughout the region. It spread first to West Africa, spread to Central and Southern Africa, and then the Hajj came, and then spread to other parts of the world. So it sent the polio eradication campaign back about 10 years, unfortunately. And so what we've been doing is we've been working with collaborators at the London School of Hygiene and Tropical Medicine and at ProMed to see if we can try to pick up on some of these changes in vaccine sentiment prior to getting to the point where you've got a dramatic boycott that starts causing large problems internationally. So we've been working on this with them, and we're just about to expand this project to multiple different languages so that we can try to get a sense in advance of not just where people are talking about vaccines, but what are they saying about this. And this is something, believe it or not, we're struggling to get funding for, but you would think vaccine manufacturers would be really interested in this. But so far they have not been amenable to that. This slide, it's a bit busy, but the point of it is just to show essentially that in these different countries, there are a lot of different vaccines and diseases that are being talked about. And this is all of the data that we're picking up in our vaccine confidence vaccine confidence project. So next, I wanted to talk just briefly about one of the things that we're doing in with some of the work looking at human rights abuses in Syria. Now this is a slide that just shows that in Hama, Syria, in 1982, there was a massacre that took place. What happened was the Muslim Brotherhood had, inspired by the Iranian Revolution in 1979, had started to form a resistance movement against the regime of Hafez al-Assad. And what happened was, once al-Assad got wind of this, he sent tanks to Hama, put a siege on the town of Hama, and bombarded it. And if anyone is aware of kind of what's been going on in Syria recently, this is often talked about, and they talk about how no one knows how many casualties there were. There's estimates between 10 and 20,000. It's just really wild, wild estimates. So this is 1982. So just to give you an idea, this is what Robert Fisk, a journalist in the UK, said about it at the time. He said, "I was, so far, the only Western eyewitness to the siege of Hama. It had been only the most cursory, the briefest of visits, but it was enough to prove that the fighting was still going on, that it was on a huge scale, involving at least a division of troops, and that casualties must have been enormous. Something terrible was going on there." So this is 1982. This is the only Western journalist that saw some of these atrocities. Now, obviously, there were lots of Syrians that saw these atrocities, but the information about it didn't really get out. Fast forward to today, and what we have is things like the Ushahidi platform that has allowed our collaborators at Syria Tracker to gather information via Twitter, via YouTube, via SMS, via email, and take all of this information and basically do validated, as much as they can, sources, validated counts of human rights abuses that are going on in Syria. And HealthMap, we've taken our digital disease detection technology and we've been pointing that at Syria, trying to pick up information about arrests, about torture, about deaths. And we've been taking this information and sending it over to Syria Tracker. But I mean, to be honest, we are one minuscule part of the amazing work that they are doing here, and I encourage all of you to check it out. So this is kind of the very broad swath of all of the work that we're doing at HealthMap. But in conclusion, just want to point out that the fusion of a mapping interface, visualization of these electronic resources is really kind of the power behind what we feel like we're doing at HealthMap. And the novel internet-based collaborative systems, they can play an important and complementary role in gathering this information. The more we work with these collaborators that are able to leverage different networks, the more data we can get and the more valid that data can be. And that's what we're really interested in. And so these are really just early efforts. I mean, you've seen there's a plethora of, in the past 10 years, a plethora of groups that are doing digital disease detection, including us. And they don't just apply to diseases. They apply to almost anything that you can think of. You can use these types of technologies and point them in that direction. So those are the conclusions. And just to spark a little bit of discussion, I just wanted to remind you of a couple of things and mention a little bit. So there's if anyone wanted to debate the sovereignty issue, that can come up. I wanted to talk just very, very briefly about the print media decline and HealthMap data. And I think privacy in these kinds of kind of digital surveillance is always an important thing that we can think about and possibly discuss. So just this is the kind of perhaps, in my opinion, overblown statements of how the world, everything's post-Westphalia now and sovereignty really just doesn't exist. So this is one thing that we could talk about. And I also just briefly wanted to mention a little bit of some of the work that I've been doing in terms of looking at how, if we get a lot of our data from media, how have some of the trends and pattern in media been affecting some of our data? So in certain places, this lists the top 10 places where what you're seeing in the columns marked 2008 and 2010 are the circulation numbers for these newspapers in these areas. And you can see there's been a vast decline. And this decline, not surprisingly, is associated with pretty much concomitant declines in their budgets, which means it's also been associated with declines in their newspaper staff. So if you have less people working on health, that can be a problem. Just anecdotally, I got this idea from the state epidemiologist in Connecticut, who told me, he said, well, you barely have anything in Connecticut. And I'm like, well, we're dependent on the news media. And he said, the Hartford Courant 10 years ago had 3 medical reporters, dedicated medical reporters. Now they have none. So he said, how do you think that's affecting your data? And I said, I don't know. Let me check. And that's what kind of embarked on this project. And this is something we've actually seen, except for a couple cities that have seen a really huge decline, we have a surprisingly robust aspect because we're able to get a lot of data from other sources. But the thing now we're starting to look at different countries because in other countries this is happening as well, and how much is this affecting our surveillance in some of these other countries is really important. Finally, there's another trend in media, and that's the issue of, if any of you have a journalism background, there's a common adage in journalism, which is, if it bleeds, it leads. So if you've got, some really fantastic picture of, explosions or something like that, put that on the front page, because that gets the most attention, that sells the most papers. So just to give you an idea, this was during the H1N1 outbreak of influenza. So what do you think happened right here? Everyone started focusing on influenza, and we saw our coverage of other diseases decline by about 20 to 25%. So this is the kind of thing where what we're going to try to do is see if we can develop algorithms to detect this kind of thing, either in advance or concurrently, to be able to suggest to our users that there might be other sources that you need to look at. This is the kind of situation where we're looking at ways to try to bring in Twitter data to be able to augment some of our HealthMap sources. So these are the kinds of the things that we're working on, and I hope a little bit of a fodder for discussion. And I just want to say thank you to all of the people, John Brownstein, Clark Freifeld, without whom I wouldn't be here, and our fantastic team at HealthMap, who's really done a large amount of work. It's a really small group that's been able to do a ton of work, and being small enough and agile enough to take on a lot of these projects has really been a fantastic experience. So if there's any questions, feel free to email me, and I'd love to open it up for discussion if people have things that they're interested in talking about. Thanks.